My name is Dr Osoinig. I'm an ophthalmologist. I'm a professor emeritus from the University of Iowa in USA. My field is standardized echography. I have been director of echography services since 1965, first in Vienna, Austria, and then at the University of Iowa. You may ask, what is standardized echography? It's an ultrasonic diagnostic method that has been developed for offering the fullness of capacities and diagnoses that are available for ultrasonography. Standardized echography is a combination of B-scan and A-scan, but the special thing is the A-scan. A-scan, as you know, shows amplitudes, but the height of these amplitudes means nothing unless all the parameters of the instrument and the technique that influence these amplitudes and their movement are standardized, especially designed. The optimal design of the A-scan instrument and probes are optimally designed for this purpose. These allow tissue differentiation and measurements that are most precise and reliable. This special design is also extended towards the examination techniques of both B-scan and A-scan. The special design of the A-scan instrument and of the B-scan and A-scan examination techniques involved in standardized echography are standardized. That's where the name comes from. This optimal design is standardized so that we speak one echographic language with reliable, understandable, comparable and repeatable optimal results. This way, standardized echography brings the fullness of all that can be done with diagnostic ultrasound in the anterior, posterior eye segments and the orbit. With B-scan alone, whether it's accompanied by the so-called vector A-scan or not, the vector A-scan is not standardized, you can get much less than half of the information that standardized echography offers. I would like to compare it with a bird. The second wing is the standardized A-scan, the first wing, one wing is B-scan echography. But without both in combination, the bird will not be flying. Standardized instruments are available from Quantel Medical. The latest ones are the CineScan S with powerful software, with automatic results, diagnosis and documentation, including CineLoop, A1 quantitative echography, 1 and 2 angle kappa and more. The newest instrument just came out is the AvisoS with software package 2010 with further improved software and high frequency B-scan. AvisoS is all digital. I mentioned that standardized echography is a combination of real-time B-scan and A-scan. The B-scan gives basic information, gives us the direction where to go from there on, but rarely gives us a final diagnosis. Who needs standardized echography? It's the specialists, of course, the retinal surgeons, for the clarification of an opaque vitreous, whether there is retinal detachment or just membranes or just hemorrhage. For the glaucoma specialist, whether there is more going on in the posterior eye segment, particularly in the periphery, when the pupil is not dilated, whenever there are opaque media, of course. I compare the role of standardized echography with that of ophthalmoscopy and slit lamp examination in clear ocular media. When they're opaque for one reason or another, then standardized echography replaces this optical means with the same purpose of arriving at the final diagnosis. Of course, in clear ocular media, when there is a tumor detected, standardized echography is also very important to differentiate those tumors. When you have B-scan, as I show you here, with the CineScan S unit obtained with 20 megahertz of hemangioma, the B-scan shows clearly the tumor with retinal detachment, but not the type of tumor that is present. For this, we need standardized A-scan. The amplitudes tell us. You have here 4 examples of a malignant melanoma in red, of a disciform lesion in green, of a choroidal hemangioma in yellow, and of a metastatic carcinoma in white. You see the difference in the height of spikes, in the length of spikes, and in addition to this, A-scan also shows, of course, the vascularity in the melanoma, which is not present in a metastatic tumor, not visible in a hemangioma. In the tumor differential diagnosis with standardized echography, the most frequent case will be that of elevated benign choroidal nevus. You see here in this picture on the left side the nevus having a high reflectivity, whereas the malignant melanoma, equal size roughly, very small tumors, has a low reflectivity, plus is vascularized. This is important not only for the specialist who gets referrals, but for the general ophthalmologist. The general ophthalmologist needs standardized echography even more so, because when there is no way to arrive at a diagnosis from the symptoms or the optical examination, the general ophthalmologist needs to make a decision whether to triage, to send to specialists, or to keep the patient and treat the patient and manage the disease themselves. A good example is the orbit. Unless you want to send any patient with orbital symptoms right away to an orbital surgeon, you need to know what the underlying cause is, whether it's proptosis or redness of the eye, whether it's pain or swelling of the lids. The diagnosis is very important to know what to do next. Here is a B-scan showing an orbital tumor obtained with the AvisoS, a nice display of the shape of the tumor in the retropalpal space, but the B-scan does not tell you whether this is what kind of tumor that is. The B-scan does not tell you what kind of tumor it is. For this we need A-scans, and here are 6 A-scan examples of the orbit of orbital tumors: hemangioma, mucocele, carcinoma, lymphangioma, cyst, and lymphoma, and you see how different they look in terms of amplitude of spikes, in terms of length of spikes, in terms of outline, whether it's infiltrative like carcinoma and lymphoma, or has a cyst wall like mucocele and orbital cyst, or is encapsulated like in hemangioma and a lymphangioma. These are only a few examples, but with standardized echography you can differentiate safely up to 50 different orbital lesions, including an important, most frequent orbital problem, Graves' orbitopathy. That their standardized echography, through its measurements of the muscles, is superior to the radiological imaging procedures, MRI and CT, as it measures the thickness of the sheath of the extraocular muscles, not just the muscles, and this way it's easy to classify the Graves orbitopathy, to know when the optic nerve is in danger and when to send the patient to a neuro-ophthalmologist or to a neurosurgeon or an orbital surgeon. The same is true for the optic nerve. For instance, papilledema. Yes, with B-scan, large optic disc drusen can be shown very clearly. Small optic nerve drusen can provide a problem, and there we need again the A-scan to clarify whether it is drusen or whether it's just a strongly reflecting surface of the elevated disc. With standardized A-scan, it's easy to measure the sheath extension of the optic nerve within the orbit in the retropulbar space and know whether there is increased intracranial pressure or not. That is so superior to measuring the intracranial pressure with lumbar puncture or from the symptoms. And so echography is not only making the primary diagnosis in many cases of the eye and the orbit, but also is very important for follow-up examinations to see the progress made during treatment.